Right, so we will start with the lecture. We have got just a couple of students, but we'll start anyway. And I think in future we will provide recordings only to those who attend the lectures, right? Otherwise, we need some people to discuss and to ask questions, right? So I will share the screen with you and then we will start with the lecture. It has taken a pretty long time for the drugs for heart failure. And right. So please let me know if you can see the screen, if my voice is clear. Write yes on the chat. All right, thank you very much. So this is the last slide we did yesterday, and we talked about inotropic drugs and the mechanism of action. Then we talked about aldosterone antagonists and their effects on the body, the effects of aldosterone on the body, right? So today we are going to start with this question, right? So I want you to read this question. I'll give you a hint, and the hint is that, right, so 4 of them are correct. I mean, the statements are correct. Right, so we'll discuss this. You see, A says inhibition of potassium excretion in collecting duct, which is correct. Spironolactone does inhibit the secretion of potassium. So Aisha said E, and there is someone DM, Dua, sorry, she said A, all right. Now, you see, inhibition of potassium excretion in collecting duct, that is correct because aldosterone increases the secretion of potassium and it reabsorbs sodium and excretes potassium, right? That is one of the effects of aldosterone. Blockade of sodium hydrogen antiporter in the proximal tubule. This is also correct because one of the effects of aldosterone is stimulation of sodium antiporter in the proximal tubule that will increase the reabsorption of sodium. And this is blockade of aldosterone receptors on the extrarenal tissues. Yes, this is also correct. And I'll tell you why. Inhibition of renin secretion by macula densa. Actually, I'm not sure about this. But one of my colleagues in my previous university, he said that it does that, but I didn't find a reference anywhere in any book, right? And blockade of sodium chloride symporter in the early distal tubule. This is also correct because aldosterone increases the activity of sodium chloride symporter in the distal tubules. And obviously, spironolactone is going to block that, right? So these 4 answers are correct. But our question is, we are asking about the therapeutic effect of spironolactone in the patient's disease. So which one of these 4 works in heart failure? That is the question, all right? Any answer? Right, here is another hint. Aisha said E. No, actually, this is again an effect in the renal tubules, but we want an effect in the heart, not in the renal tubules. Okay. Well, the correct answer is blockade of aldosterone receptors in extrarenal tissues, and heart is, I mean, this is an indirect question. You do get questions like this sometimes. They are more for your practice, for the examinations. But if you think we are asking about the therapeutic effect of spironolactone in heart failure. So these are not the direct therapeutic effect of aldosterone in heart is prevention of fibrosis by aldosterone in the heart, okay? So this is the correct answer, blockade of aldosterone receptors on the heart, okay? Right. So let's go ahead. We did most of the drugs. We have seen that the inotropic drugs, they support the Frank-Starling mechanisms. We have seen that beta blockers, they counter the effect of sympathetic nervous system stimulation, which increases the heart rate. So we try to slow down the heart rate. We have got a new drug which slows down the heart rate. I'll show that to you in a minute. Renin, angiotensin, aldosterone mechanism, which is counteracted by aldosterone antagonists. All right. Then endothelins, which cause vasoconstriction. We saw that we give vasodilators as well. And inflammatory mediators, well, they are used for as biomarkers. Myocardial hypertrophy and remodeling and fibrosis. This is counteracted by spironolactone. And sorry, this renin, angiotensin, aldosterone system is opposed by ACE inhibitors that we use, but we have other drugs which are more preferable now. All right. So basically, my lectures was based on the effects, the deleterious effect on the heart in heart failure that we try to stop or slow down with certain drugs. Okay. And through that, we have covered almost all of the drugs. Now we are going to look at natriuretic peptides, right? Natriuretic peptides are beneficial for the heart. So we want the natriuretic peptides to be there. And we have luckily got a drug since the last few years that works over here. Sorry, I just lost my, right. So this is a study which was published in 2016 over here. And it says that valsartan, sacubitril, and ivabradine are recommended for heart failure in updated guidelines from American Heart Association and American College of Cardiology, right? So let's see what this is a combination of drug. You know what valsartan is. Valsartan is an angiotensin receptor blocker, and sacubitril is a neprilysin inhibitor. That is why we call them ARNIs, angiotensin receptor, and neprilysin, ARNI, angiotensin receptor and neprilysin inhibitor. And ivabradine, I will show you this drug as well, okay? So atrial natriuretic peptide is produced by the heart muscle as a result of stretching of the heart. You know, in heart failure, the heart dilates and the muscles, the wall is stretched, the wall is under tension. Stretch of atria stimulates production of atrial natriuretic peptide, or BNP, which is brain natriuretic peptide. We call it brain natriuretic peptide because it was first isolated from the brains of the pigs, all right? Now, antagonist to aldosterone and angiotensin 2. Good, that is a good effect because both aldosterone and angiotensin 2 cause remodeling and fibrosis and increase in extracellular matrix in the heart, all right? It promotes sodium and H2O excretion in the urine by the kidney. So that is a good thing. Excuse me. Sorry, I will just this call from my friend. All right. So we know that aldosterone causes sodium and water reabsorption, retention, and it increases the blood volume. And if you increase the blood volume in heart failure, that means you are increasing the afterload and you're increasing the preload as well. It promotes vasodilation, which is a good thing in heart failure. Over here, you know, I'm showing you in green. Green means good and red means dangerous. So natriuretic peptide system, functions of the natriuretic peptides, it has got two receptors, A and B. And the effects of this natriuretic peptides are natriuresis, diuresis, and decreased renin secretion. Both are good effects. They decrease the volume. Vasodilation and decrease in blood pressure. Endothelial permeability is not directly related, but it does that. It increases endothelial permeability, but it reduces blood pressure, which is a good thing in heart failure. It decreases hypertrophy and fibrosis that is caused by angiotensin 2 and aldosterone. So another good effect. and sympathetic outflow is decreased, the arrow is going down. That is also a good effect because sympathetic outflow increases the heart rate. It might increase the blood pressure as well, and we don't want that. But the unfortunate thing is that this natriuretic peptides is destroyed by neprilysin into inactive fragments, right? So we don't want this thing. We want them to be there. We don't want them to be degraded by neprilysin, right? Now, on the other hand, we have got renin, angiotensin, and aldosterone system, which will ultimately produce angiotensin 2. And we have seen that angiotensin 2 has got so many effects, sodium and water retention directly and through aldosterone as well. It causes vasoconstriction through stimulation of the sympathetic nervous system, and it can directly cause vasoconstriction. So it will increase blood pressure and it will increase endothelial permeability. Hypertrophy and fibrosis, both angiotensin 2 and aldosterone can cause hypertrophy and fibrosis, and sympathetic outflow is going to increase as a result of angiotensin 2, all right? And in addition to that, it increases the secretion of antidiuretic hormone that will increase the plasma volume. So that is also not a good thing. So we need a drug. We need a drug which is angiotensin receptor and neprilysin inhibitor, right? And that drug is what I will show you in a minute. It is so here it is. This drug and this neprilysin inhibitor is going to block this thing, this part. So we will get higher levels of natriuretic peptides, which is a good thing. And it is going to block ARB, the valsartan is going to block the effect of angiotensin 2. Again, that is a good thing. So valsartan and sacubitril, whatever it is, I'll just tell you, yes, sacubitril, right? So ARNI is sacubitril and valsartan, a combination which will increase the level of natriuretic peptides, atrial natriuretic peptides, and it will decrease or block the effects of angiotensin 2, all right? And we get them in different combinations, C24, 26 milligram, 49, 51 milligram, 9700 and 3 milligram. Now, you might ask me that, why is it 51 milligram? Why not 50 milligram? Well, the drugs company give you reasons for that. I don't have reasons. Same, why do you give 81 milligram of aspirin in heart failure? Why not 80 milligram? Why not 82 milligram? Well, they have somehow calculated that dose, and they are producing that the tablets, that you usually give for antiplatelet effects, all right? So this is one drug which is used, and the role of neprilysin inhibition in patients with heart failure with reduced ejection fraction. They have various beneficial hemodynamic and cardioprotective effects that we just now discussed, and they counteract the deleterious cardiovascular effect of sustained sympathetic nervous system and renin, angiotensin, aldosterone system activation, right? So basically, we have already discussed that sympathetic nervous system is not good, and that is why we were giving beta blockers, and RAS activation is not good, and that is why we were giving ACE inhibitors and ARBs. And also, because RAS activation increases the blood volume, so we were using diuretics as well in heart failure. Thus, increasing the levels of endogenous natriuretic peptides has become a focus of novel heart failure therapies. One way to increase endogenous natriuretic peptide is to inhibit neprilysin, and that is exactly what we are doing with the help of these drugs, sacubitril, all right? Right, and this is another study published in 2020, right, and International Journal of Heart Failure. It is a good journal, high impact factor. So recent large-scale randomized clinical trials have provided compelling evidence that sacubitril, valsartan, and angiotensin receptor neprilysin inhibitor is superior to ACE inhibitors in reducing mortality and heart failure hospitalization and in improving quality of life in patients with stage C heart failure with reduced ejection fraction. So that is why Now, in place of ACE inhibitors, ARBs, well, this is an ARB, ARNI is an ARB, but this combination has replaced ACE inhibitors. And if a patient cannot tolerate this, in that case, we can go back to ACE inhibitors. All right. Now, this is a balancing act, and I'm sure now you know that. This is angiotensin is trying to cause aggravation of heart failure with all these effects, increase in blood pressure, sympathetic tone increase, aldosterone, fibrosis, hypertrophy, and these are all the good effects of natriuretic peptides, which are given over here. So we have a balancing act in the body, and we don't want to disturb that. So the problem is that neprilysin inactivates this, and so we have got the therapy which will increase the levels of natriuretic peptides, and it will decrease the levels and block the angiotensin II receptors. All right. So we have already seen this slide previously. We use ACE inhibitors in all stages, almost all stages, maybe in stage 1, which is just the risk, depending upon which classification you are following. But if you're following HFrEF and HFpEF classification, which is based on ejection fraction, then in both HFrEF and HFpEF, these drugs are indicated. Beta blockers are indicated, and ARNIs are also indicated over here, and mineralocorticoid receptor antagonists. We know that they are also now the top drugs in combination with the others. All right. Right now we go on to Ivabradine. Again, this is a new drug, and fast resting high heart rate is a problem in failing heart. We want to slow down the heart, all right? We don't want the heart to spend a lot of energy. We want to counteract sympathetic overactivity from neurohormonal activation, and has been shown to have detrimental effects on hospitalizations and mortality in heart failure, both in HFrEF, reduced ejection fraction, and preserved ejection fraction. So we all agree that sympathetic stimulation is not good, and we give beta blockers for that, all right? Now, not all patients with HFrEF tolerate beta blockers or achieve doses high enough to adequately reduce resting heart failure. So clinical trials have shown that Ivabradine reduces heart failure hospitalizations in those who have got reduced ejection fraction, right? The mechanism of action, it is selective inhibitor of funny current, right? In the sinoatrial SA node, which is the pacemaker, and inhibits the sinoatrial node pacemaker activity in a rate-dependent manner. Now, you'll see that just like beta blockers, it has almost a similar effect, but through a different mechanism. This leads to decrease in resting heart rate via a mechanism different from that of beta blockers. So beta blockers also slow down the heart rate. They increase the time of diastole. They increase and they give an opportunity to the heart to fill with blood, right? The longer the diastole, the more time is there for the ventricles to fill with blood. So, okay, so this is also doing the same thing, but in a different way. This is the sinoatrial node, the pacemaker of the heart. So here I've shown you the funny channels. You know what are the funny channels? You know, after the action potential is over, right? And the potassium channels open up. So I'll start from the beginning. You know, the phase 0 of the action potential is that the sodium channels open up. So the potential goes up. We get depolarization. Instead of a negative potential, we get a positive potential. Then there is a slight depolarization because of potassium efflux, but then it levels off. There is a plateau. And what is happening in the plateau phase? Calcium is moving in and potassium is moving out, and both are almost balancing each other. Then we get the phase 3, which is the influx of calcium stops and outflux of potassium increases, right? So when the potassium, the positive charges goes out, the membrane potential will be restored. Okay, it is repolarization, and it will go back to minus 90 millivolts, right? I hope you are with me so far. Now, after that, what happens is when the resting membrane potential is minus 90 millivolts, in the membrane, there are these funny channels. There is some reason for calling them funny. Maybe they didn't know what this channel, or how to name this channel, whatever the story behind this is. But the sodium slowly starts leaking in through the funny channels, slowly. So what happens is, now we are talking of the phase 4. Phase 3 was repolarization, when potassium moves out. Now in phase 4, slowly sodium is going to move in, and this minus 90 will increase slowly, minus 85, minus 80, minus 75, minus 70, and at around minus 70, minus 65, that is the threshold potential, and we again get influx of sodium. The fast channels open up, and sodium flows in, and we get another action potential, right? Now, when we block the sodium channel, these funny sodium channels, see this. So let me show you once again. All right. Actually, over here, it's what I explained to you just now was the action potential in the cardiac muscle. It is a little bit different in SA node, because the upward this spike is due to calcium channels. Okay. But anyway, see what is happening over here is, it is at this, in this phase where the funny channels are open, okay? And slowly sodium is moving into the cells, which means that the positive charges are moving into the cells, and inside the cells, we are getting more positive charges. So this is minus 90 millivolts, and slowly it is going towards the threshold. And as soon as it reaches the threshold, it will fire once again, right? Now, this change in membrane potential is due to these funny currents, okay? Funny sodium current. So normal time to reach threshold potential. And when we give ivabradine, ivabradine is going to block these funny channels. So what's going to happen to the phase 4? It will be prolonged, right? Ivabradine mediated increase in time to reach threshold. So you get a slowing of heart rate. How do beta blockers work? Beta blockers block the activity of norepinephrine, right? But this ivabradine is working directly on the funny channels, right? I hope everybody got this point. So let's go forward. It causes a decrease in heart rate. So these are a few clinical trials that have been published lately, and there are some more new drugs. Vericiguat is a new drug, which is a soluble guanylyl cyclase stimulator. I'll show you this in a minute. Sacubitril and valsartan we have already discussed. Reassessment of spironolactone, mineralocorticoid receptor. Now it is one of the preferred drugs. Then we have got dapagliflozin and empagliflozin, which are SGLT2 inhibitors. All right, so we'll now look at these drugs. These are the 3 new drugs. These are now in, we are using them clinically. Vericiguat, I am not sure how commonly it is used, but we have got a production by one of the pharmaceutical companies that I'll show you. Omecamtiv. Omecamtiv, I don't know whether it is in clinical use or not, but it has been approved by FDA. All right, so let's first look at omecamtiv. Activates cardiac myosin. What is myosin? Can anybody tell me? What is cardiac myosin? What does it do? Any ideas? All right. Well, it's simple. It's actin-myosin interaction, sliding of the filaments, cross-bridge formation, if you remember from your physiology. So it activates cardiac myosin. I'll discuss this in a little bit more detail in the next slide. Augments speed of ATP hydrolysis, right? I'll again remind you what happens in the cross-bridge cycling. it is activating the contractile apparatus of the myocardium, accelerates production of a strong actin-myosin complex. It is a myotrope, not an inotrope, okay? And then you see, now point to note, not an inotrope, okay? Results in increased force production, not an increased force of contraction. It is not increasing the force of contraction. What it is doing is, it is increasing the duration and effectiveness of contraction. All right, so that is what it is doing. Sustained contraction will keep the aortic valve open and the blood will keep flowing out. So that means it is increasing the cardiac output to some extent. Now here is the cross-bridge cycling, you know. This is myosin head and this is actin filament. Now you know that once to detach, we are starting from the end. To detach from actin filament, it needs ATP. It does not need ATP for the power stroke. It needs ATP to detach itself from the actin filament. And if you remember this, what do we call that? Rigor mortis. In a dead person, the body becomes stiff because the myosin and actin are bound to each other and there is no ATP available to separate them. So the body is stiff, the muscles are in a sort of contractile state until the proteins break down and the proteins, you know, they denaturate or whatever you call them. So ATP binds and it separates from actin, and then ATP is hydrolyzed. Now, when ATP is hydrolyzed, it gets a potential energy. It is like in a cocked stage. Okay. Then when the calcium flows in and tropomyosin, you know, the filament that covers the active sites on actin filament, calcium moves in and that exposes the binding sites for myosin on actin. So myosin binds over here, and because it had this potential energy, so it will execute the power stroke, right? And the filaments will slide on each other, which means it will cause muscle contraction, right? Force production. Now, and the cycle goes on. Okay, it will execute the power stroke, and then ADP will separate. You know, here the ATP broke down into ADP. Now here finally ADP is released and ATP binds again and it detaches again. Now, what is this drug omecamtiv mecarbil doing? All it is doing, I'll explain. They have written two things that I've shown you over here, but let me give it to you in simple words. It increases the number of cross bridges. It increases the number of myosin heads that are binding to actin filament. That is what it is doing, right? So through that, it will increase the duration of contraction because it will take a longer time for myosin to detach from actin filaments. So that is the proposed mechanism of action. Now, whether it is in clinical use or not, I'm not sure about that. But this Vericiguat is definitely, you know, this company, whatever its name is, I don't know whether it's written over here or not, but this is, you see, this is the national drug code for USA. Anytime you see this NDC and 10-digit number written over here, that means it is from USA. So this Vericiguat, these are tablets taken orally, and I'll show you the mechanism of action in a minute. It is a soluble guanylyl cyclase or guanylate cyclase inhibitor, stimulator. Indication to reduce the risk of cardiovascular death and heart failure hospitalizations, or need for outpatient IV diuretics. So reduces death, reduces hospitalization, and decreases the need for IV diuretics in adults with symptomatic chronic heart failure and ejection fraction less than 45%. Starting dose is 2.5 milligram, maintenance dose is 10 milligram, but you go slowly. You double the dose every 2 weeks. Adverse effects are hypotension, anemia, and fetal toxicity, right? So here is the mechanism of action. What is happening in heart failure is, because, you know, there is inflammation, and whenever there is inflammation, there is going to be oxidative stress, And whenever there is oxidative stress, there is going to be endothelial dysfunction. And this endothelial dysfunction will reduce the amount of endothelial nitric oxide synthase. So we will get a decreased amount of nitric oxide, which is a vasodilator. And nitric oxide actually stimulates soluble guanylate cyclase. So GTP will not be converted to GMP because that's what the function of guanylate cyclase. Adenylyl cyclase converts ATP to cyclic AMP, right? Guanylyl or guanylate cyclase is converting GTP to cyclic GMP. So the levels go down, and myocardial, as a result of that, there is myocardial dysfunction and vascular dysfunction. Now, what is Vericiguat doing? It enhances the sensitivity of guanylate cyclase to nitric oxide. So there will be a greater activity or increased activity. It also directly stimulates this soluble guanylate cyclase. So what will happen is that we will increase the levels of cyclic GMP, and these dysfunctions will be reversed, or they will be neutralized to some extent. All right. So that was about Vericiguat. Now we come to the last drug that are again new drugs, at least for the treatment of heart failure. And you know that these sodium glucose cotransporter 2, they were basically used for type 2 diabetes, right? Canagliflozin, dapagliflozin, empagliflozin, and we have got one or two newer drugs in this category. They are known as gliflozins. So these are some of the brand names, and they come as tablets, so they can be taken orally. Dosage once daily in the morning. Canagliflozin should be taken before first meal of the day. Metabolism is glucuronidation that will make it soluble, and it will be excreted by the kidneys. Excretion, canagliflozin mainly via feces. About 1/3 is renally eliminated. That 2/3 will go out through the liver, excreted by the liver. And they are contraindicated in renal dysfunction, although liver is handling the greater portion, but still they are contraindicated in renal dysfunction because their mechanism of action is mainly in the kidneys. All right. So this is your kidney, and this is the glomerulus. This is your proximal convoluted tubule, and this is the loop of Henle and distal convoluted tubule, right? SGLT is responsible for reabsorbing up to 90% of glucose filtered in glomerulus. So that is why we were using it for type 2 diabetes, right? So let me enlarge this one and even more magnification. So glomerulus, okay, efferent arteriole and efferent arteriole filtration, glucose will be filtered. A lot of glucose is filtered over here. 100% is reabsorbed by the proximal tubules, okay, or by the kidneys. But through, how is it reabsorbed? 90% is reabsorbed by, I'm now going to enlarge this one cell, and this cell on the luminal side. This side we have got the blood, inside is the lumen. On the luminal side, you see this glucose. This glucose will be taken up. It is sodium glucose transporter. So there is always a sodium gradient. More sodium over here, less sodium inside. So with the help of sodium gradient, glucose will also come in, and it will go into the blood. So that is what SGLT2 transporters is doing. It is reabsorbing about 90% of the glucose that goes back from the kidneys. All right. You block this glucose will not be absorbed, and it is good for type 2 diabetes. But the clinical trials showed that this has got a very good effect on the cardiac, especially in heart failure patients. It was reducing the number of hospital admissions, right? And it had such a good effect that they reclassified it as a cardiac drug as well. It is a diabetic drug as well as, and it is a cardiac drug. as well. Okay, so this is the mechanism of action. By inhibiting SGL2, these agents decrease the reabsorption of glucose, increase urinary glucose excretion, which is a problem, and it lowers blood glucose, but it is not an antihypertensive drug. Okay, inhibition of SGLT2 also decreases reabsorption of sodium, and it causes, both the increase in sodium and glucose in the tubules will cause osmotic diuresis. But the increased secretion or increased amount of glucose causes problems in the urinary tract. Okay, they're not indicated in hypertension. They cause a little improvement of blood pressure. So the adverse effect, the most common adverse effects are female genital mycotic infections, vulvovaginal candidiasis, urinary tract infections, and urinary frequency, right? So obviously this is an osmotic effect. Hypertension has also occurred, particularly in elderly patients on diuretics. I don't know what the mechanism is, but the bottom line is that clinically, I don't know the reason exact how it works in the heart, but what we have seen in clinical trials is that it is good for heart patients, and it is so good that it has reduced hospitalizations, and it has shown a lot of improvement in the condition of heart failure patients. All right. Thus, volume status should be evaluated prior to starting these agents. And because this slide is from diabetes lecture, so I've given some other drugs as well. Right. So they are easy to use. They have fewer contraindications. We give a single dose, minimal effect on heart rate or blood pressure. They are renoprotective, and there is a small decrease in estimated GFR, but their benefits far outweigh these small little harmful effects, right? So in heart failure, we have seen that a combination of ARNIs and SGLT2 inhibitors, they are additive in their effect. Okay, two drug classes add incrementally to each other, can and should be used together. Adverse effect profiles are complementary. One may enhance tolerability of the others, but again, weighing the benefits against the risks, the benefits are too big. All right, and that is all for heart failure. And we took a long time, but I hope you benefited from this. If you have any questions, I am here to answer your questions. All right, and if there are no questions, then we will stop here. There is something over here on the chat. All right, you're most welcome. Now what we'll do is we will keep going with some other lectures in the cardiovascular system. But the problem is that when I post the lectures, people stop attending the lectures. I need at least some students to attend the lecture, because there is a discussion when people attend the lectures. All right. Those who attended the lectures, I will definitely send them the link to the recorded lectures. So thank you very much, and I'll see you next time.